So, Michael, what do you think of this case?
T2 and a T1 fat saturated image. Looking at this. Okay, so on the T2, I see this focus of abnormal signal, the distal supraspinatus tendon there, that I don't necessarily see on the T1 fat saturated images. So that is, yeah, it looks like an interstitial type tear. T1.
So this is a partial interstitial tear at the foot plate, which are fairly common lesions, and they can be symptomatic. But if you don't have a fluid sensitive technique, you'll miss those and maybe a cause of symptoms. I generally, if these don't communicate, most people I know will not operate on them. That doesn't mean everybody wouldn't operate, but this can explain the symptoms. And so I think it's important not to miss. So just remember, I've seen there's still a few people out there when they do arthrogram studies, they only get T1 FatSats in all three planes. And if you do that, you're going to miss significant lesions. And we saw this in the knee, and we'll see it in every other joint that we see. So it's important to make sure you get fluid sensitive images.
There's only one reason to operate on this. Only if you're going broke and need the money.
Okay, Aram, what do you think of this case?
So it looks like we have an arthrogram fat saturated T1 sequence. I mean, I see part of the, there's the biceps labral anchor we're seeing. It looks like there's contrast extending deep to it, although that could just be adjacent to the coracoid.
Let me give you another sequence here.
Yeah. So extensive fluid associated with the foot plate of the supraspinatus, and looks like, this is a near full thickness tear, probably extending from the bursal surface in. So there's probably still some caps, what do you call it, articular surface fibers intact, so you're just missing it on the arthrogram part.
Yeah, so it's the same point we made with the last one. So it's just, again, and there's just other images showing that we have a non-communicating partial tear that's near full thickness. And there it is on the sagittal images. But contrast doesn't go through. Okay, Sheila, what do you think of this case?
Okay, so this patient looks like they had prior rotator cuff repair, and it looks like now there's fluid at the distal insertion of the supraspinatus tendon. So it looks like there might be a partial tear because I think I see some fibers still at the insertion site.
Yeah, a couple of things to point out here. One is we see a little bit of fluid in the subacromial subdeltoid bursa, but is it contrast? If you look on the T1 FatSat, it's not contrast because it's not bright. So this is not a communicating lesion. But however, it's important to know that it is common to get communication between the joint space and the bursa after surgery, even when everything is perfectly fine after surgery. So once you've had surgery, communication is a normal finding. In this particular case, you don't have it. What this is primarily pointing out is if we just look at the PD FatSat, when you do FatSat images, when you have, in this case, a suture anchor in place, you get increased artifact, and it can be very difficult to evaluate to see whether the surgical construct's intact or not. I've really found that the T2 non-fat suppressed image is much more reliable for that. In this particular case, there's no proximal retraction of the musculotendinous junction. We see no communication between the two. And if you follow this, we have fiber structures intact all the way to the suture anchor placement. So this is an intact construct. And you can be most comfortable that it's intact really by looking at the combination of the T2 and the T1 FatSat images to make sure there's no communication and that we don't have proximal retraction or a complete breakdown of the construct. So that I think the T2 non-fat suppressed image is very important in evaluating the postoperative shoulder.
But it's not a perfectly normal tendon in that there is post-surgical changes or partial tears or whatnot there, correct?
There's never a normal tendon after surgery.
Perfection is in the mind of the beholder.
So from the surgeon, it's perfect.
From our standpoint, then, as we're reviewing it, then, as long as the tendon is still partially intact, that's really what's most important after surgery. Rotator.
No.
The most important thing is function. It's not what it looks like. All you can do is describe what you see, and then let the people decide on the clinical side what to do with it.
So what you look for primarily is to see whether things are mechanically intact, which is what we see in this particular case. It doesn't mean the patient's not symptomatic. Obviously, the patient's probably symptomatic because they did an MR study in it. And whether or not you need to reoperate is based upon the clinical findings, like John was talking about, as well as the information we can give them concerning the anatomy that's there. So it's a combination of factors. And so a lot of people like to say you don't operate on an MRI, you operate on the patient. So you get two separate pieces of information. There's the clinical information, which is essentially absolutely important, and then there is the anatomic information and some biochemical information which you get from the MR, which is less important, but still critically important as to what can or cannot be treated surgically. So they're two kind of separate pieces of information. You've got to put them together to determine the proper course of management of the patient.
They basically are giving a surgeon a map on what to do or what can be done before they put the knife to the patient. That's basically what it is. You're just making a roadmap for them. And the patient and the surgeon decide what they want to go and do.
People out there, can you hear John Urgutis when he talks? Yuri?
No.
No? Okay. So, John, when I hand this to you, man, you can just pull it over there and scream right into it. That would be good. Okay, good. I'll hand it to Sheila, and she can hand it to you that way. Okay. Okay, so that just shows what I think is the importance of having the non-fat suppressed T2 weighted image and evaluating the postoperative shoulder. This just shows a patient who was injected with contrast, and there's a subacromial injection. We saw an abnormal injection earlier, so the contrast is all in the not in the proper location here. It's not in the joint space, but in the subacromial. And here's just an injection within the supraspinatus muscle and tendon, which is also not a good place to inject the shoulder. Just showing abnormal injection patterns. The ABRA view, this was really first described by a former fellow when I was in Santa Barbara, Philip Tierman, where you put the arm over the head. So it's the abducted external rotation view. Initially, this was thought to put tension on the anterior labrum, and therefore if you have an anterior labral tear, it would separate it, make it easier to see. And that's true if you have a tear that actually goes through and also tears the periosteal attachment of the tendon. That can happen, of the labrum. There are still a fair number of labral tears called Perthes lesions that we'll talk about later, where the periosteal attachment's intact, and when you do this view, it often actually compresses it and makes it less visible. So, or in general, occasionally I found it helpful, but in about 200 cases that we did at Orange a number of years ago, I found that only in about 2 cases did it actually allow us to see an anterior labral tear better. What it does, however, and we'll talk about this more when we talk about the athletic shoulder, it allows, I think, much better visualization of the posterior superior part of the joint space in the capsule, which is the area where we get posterior impingement. And therefore, I now limit the ABRA view to arthrography and the young overhead athletes, throwing athletes. Otherwise, we've dropped and we don't do this. Now, a lot of people would disagree with that. There are people who will say that this is an important view for everyone. But it's tough for older people to put in this position. They get very uncomfortable. They tend to move a lot. The anatomy gets a little difficult if you haven't seen a lot of these, because when you reposition the patient, everything moves. And it takes a lot more time. So it's much more expensive to do the ABRA view. And I've only found it helpful in the overhead athletes. So we've limited our use of the ABRA view just to the overhead athletes.
You better have a lot of morphine around when you're going to do that study, because anybody with a sore shoulder is not going to allow you to do this view.
Yeah, actually, we should talk about that. And that is, probably none of you have had shoulder problems and been in an MR scanner. Uh, it's amazing how painful a shoulder can get when you have to lie still in the scanner for any period of time if you have pathology. Uh, as most clinicians would tell you, and I'll give it over to John here and see if he'll confirm it or not. But one of the biggest problems that people have when they have shoulder pathology is inability to sleep at night because you get a lot of shoulder pain at night. That's the worst time. And what I found when I had a rotator cuff tear, when I was in the scanner, I was fine for about 4 or 5 minutes. But then if I had to stay in one position for any longer than that, it got excruciatingly painful. And it's even worse when you have to put your arm above your head. So uh, the most important thing that you need to do in a scanner if you're scanning a shoulder is make sure the patient is as comfortable as possible because you want images without motion artifact. And so we often have to compromise our position. I didn't really say it like I should have before in the earlier part of this lecture, but typically what we like to do is have the humerus in external rotation. So it's very important not to put the forearm on the abdomen when you scan someone for two reasons. One is that pushes the humerus in internal rotation, and if people are breathing, a lot of abdominal breathers, well, that will cause motion of the arm, which will translate up into the shoulder, and you'll get motion artifact in the shoulder. And that's a major cause of motion artifact. So the hand should never be on the abdomen. It should be at the side. The palm should be up, and you should be externally rotated at the elbow, is the way the tech should be taught. However, patients who have real pathology in the shoulder may find that position very uncomfortable. So you may have to image patient in internal rotation of the humerus because that may be the only position where they're comfortable enough to be able to go through the scan.
Yeah, when people come in with shoulder pain of any significance to the office, they won't allow you to abduct past 60 or 70 degrees. Anybody can abduct past 90 degrees, won't be in your office. They'll be at a family doctor's office getting aspirin or something. So when they come to a specialist for a shoulder problem, they usually are not moving very well at all. So when you do a Faber view, which means you have to bring your arm over the head and internally rotate it, or abducted, I should say. I guess it's an abduction external rotation, and they will not allow that. And if they allow it, there's no need for treatment.
Okay. So that's a neighbor view where we didn't see the labral tear in the traditional position, but we can see the anterior labral tear in the ABER view. And we'll see more examples of this later. What this actually shows is that there's a posterior superior labral tear, and that's very important when we talk about athletes because that's a common location of athletic injuries. So, Yuri, what do you think of this case? This is an arthrogram.
Okay. There's increased signal intensity within the intrasubstance of supraspinatus, and actually at the superior fibers of the subscap tendon.
Well, we don't. You mean up here?
Oh no, on the other side, there's increased signal intensity.
Here?
Mm-hmm. And
okay, but what about all this stuff in here? In this, with an
right, the
arthrogram,
capsule.
it's usually bright on a T1 weighted image.
Right. I think it's probably too dilute. Too dilute. I think we probably have a dilution issue.
We do have a dilution issue, but it's not too dilute. It's not dilute enough. This was it was too concentrated. They actually put in a 1-to-1 dilution. It should be about a 1 to 200 dilution. And when you do that, when it's too concentrated, as we'll talk about in the physics section, you not only have a decrease in the T1, which makes it bright on a T1 weighted image, but you have a decrease in the T2, which causes it to be black on all image sequences. So this is what it looks like when they inject too concentrated a contrast. And here we can see in this patient, this is actually a little bit of imbibation of the contrast here. This is very black contrast. These are T2 fat suppressed images. Notice how grainy they are, but we can see very little loss of signal intensity there. Now, in this particular patient, and I'll show other examples when we get to talking about pathology, if you see this, which you shouldn't very often, but we still do occasionally, if you try to bring the patient back right away, often 4 hours later, the contrast will be just at the right dilution. And without adding another injection, you can actually get a good quality study. So if you see this right away, have them call the patient back, readjust the schedule, and scan them right away. And you can end up with a good quality arthrogram if you do that. It will be partially absorbed, which is what you want, because it'll absorb enough of the contrast so that you'll have a dilute contrast and you'll get the proper contrast. So typically around 4 to 8 hours, if you have a full concentration of 1-to-1 dilution, you'll have about the appropriate amount of dilution, and you'll still have increased fluid in there. Probably because of the irritation of the contrast. If you wait till the next day, then all the contrast will be gone. So just something that can be helpful. Something that some people have recommended, and there's still a few places that I think do this, is indirect arthrography, and that's where you inject someone with IV contrast, you exercise for 20 or 30 minutes, bring them back on the scanner, 30 minutes after the injection or more. And then what you do is get enhancements of the surrounding soft tissues, but especially if you have synovitis, you'll then also get contrast extending into the joint space. And some people call this a poor man's arthrogram. This is the T1 pre, this is the T1 FatSat after contrast in an indirect arthrogram. The advantages of the indirect arthrogram is that if you have pathology around the joint or synovitis, it might enhance. In this particular case, we can see enhancement in a bursitis. The disadvantages is that you don't really distend the joint, which is one of the advantages of arthrography, and you often get suboptimal contrast within the joint space itself. Most people who are strong advocates of this, at least for the large joints now, no longer are strong advocates. It's pretty easy, especially using the rotator cuff interval technique, to do a direct injection. So I don't see too many people doing this anymore, though I have seen it still in the hand and wrist and some of the small joints.
In terms of injecting gadolinium, regarding the nephrogenic sclerosis problems you can have, is arthrography any problems with that?
In terms of nephrogenic sclerosis, no, there's never been a case of anyone who's had arthrography that's got nephrogenic systemic sclerosis. There's been no new cases reported in the last 3 years. So it's really it was a disease caused by massive overload of people primarily in the hospital setting with renal failure who were sick patients with the disease, and it's almost certainly due to increased gadolinium in the tissues. It's virtually never really occurred in the outpatient setting. There will be people who may hear this lecture and disagree with that, but it's extremely rare. And right now, even if you have all the highest risk factors, the highest risk for developing of NSF with a contrast injection was around 3 to 5%. It turns out now that if you're aware of the problem and you try to limit the dose to the minimum amount necessary to find the information, the risk of getting nephrogenic systemic sclerosis, even for high-risk patients, is less than 1%. It's very negligible now, but people in the past used to give triple doses for vascular studies. They used to bring it in a hospital setting. They might get gadolinium 3 or 4 times in a week, and they were very sick patients, and those are the people who tended to get it. So it's really a disease that's almost historical now. Again, I don't know of any new cases in the last 3 to 4 years.
Not to kind of distract on this topic, but so what do you think then in terms of high-risk patients? We're talking about end-stage renal failure. What about now it's kind of monitored in the community? If you have, you know, a little bit of low GFR, we won't give it anymore.
No, you have to, if you have a mild degree of GFR abnormality, we give it freely. We will only restrict it if the GFR is below 15. I think the risk is only if you have very severe renal disease. Moderate renal disease, no one has really clearly shown that there have been any substantial number of cases with GFR around 30 that have actually developed the disease. So, and even now, if you have someone who's in full renal failure, still we could give it because it still may provide information that's much more critical for that person's life than the potential risk of NSF, since it's such a low risk right now. Again, it was a problem back when it was given in massive doses. I think the biggest risk right now is for people to do suboptimal imaging because they're concerned about NSF. Since the risk factor is so low, the risks are probably higher by not imaging appropriately. But I say that, on the other hand, I rarely like to give contrast. So I only like to give contrast when there's a high chance that it's going to be useful, because I think MR is a great technique in the musculoskeletal system for almost everything, including bone tumors, without the need of contrast. But one area where I find it very helpful is in the diabetic foot that we'll talk about. And there, the diabetics are often patients who are at increased risk. But still, a diabetic foot can be a life-threatening problem. So I still believe that it should be given in the appropriate setting, even in a patient who's diabetic and has renal failure. But we'll talk more about that when we get to the diabetic foot. Okay, let's see. Is just, and then if somebody does have problems, you can do CT arthrography looking for the shoulder, but you're all aware of that. This just shows a contrast going into the subacromial subdeltoid bertha CT. One thing that occasionally we see are individuals who come in who can't have an MR because they have a pacemaker or something, can't have CT arthrogram because they've got a documented sensitivity reaction to iodinated contrast material. It's not an allergy, so please don't call it an allergy. It's not an IgE-mediated response. So what do you do with that? And this just shows two vials. This is in a CT scanner. This vial is with iodinated contrast. This vial is undiluted gadolinium. So gadolinium is actually dense on a CT scanner, and this is a case of a patient who couldn't have an MR scan, couldn't have iodine, and this is actually a CT scan, CT arthrogram using undiluted gadolinium in this particular case, showing free flow of contrast into the subacromial subdeltoid bursa, showing that there's a complete rotator cuff tear, and this patient then went on to repeat surgery to correct that. So just remember that occasionally gadolinium can be used even in a CT scanner. So,
Air for arthrograms?
the question was, do you ever use air for arthrogram and MR? The answer is no. It produces too many artifacts. Certainly with CT, double contrast arthrography, or with plain films, that was the standard in the past.
It's been done by accident, I imagine. It's been done by accident, I imagine.
Yeah, unfortunately, it's not uncommon to see air in the injection, but we don't mean to do that. Okay. Let me just.
We all know what we're talking about.
Thank you.
Yep.